but I am asking you to touch so that you'll know, is that skin attached or fake attached? Because that's what? That's the line between first degree and second degree. Does that make sense? First degree I don't include, not clinically significant. If it really is only fake attached, that really is second degree, I'm in the dermis, I include that. Does that distinction make sense? So please touch, don't just look, but touch. And when you're touching, you're looking for three things when you're touching. What three things?
What is the temperature?
Yeah. Oh, well, that's a fair point too, but in terms of depth assessment, that's a poorly worded question. You certainly would be concerned about temperature, absolutely, but do you have cap refill? Do they feel pain? And is that epidermis really attached or fake attached? Does that make sense? While still doing your normal, CMS, color motor sensation, etc., etc. And I would say cap refill is, it's not just do they have it, but how long does it take, right? Brisk versus sluggish, all of that stuff. All right, so what do you do once you've added up all the numbers and have a percentage? That's your total body surface area. 30% burn is 30% of their body's skin surface area is now injured, at least second or third degree, whatever. So that brings us to the Parkland, the modified Parkland, also known as the consensus formula. I suspect when you were taught burns, you maybe were just told 4 mLs times percent times weight in kilos. That's the classical Parkland formula, 4 times weight times percent. Meta-analysis suggested back in the mid-2010s, this is what the formula said, how much are patients actually getting, and looking at lots of data, found out that fluid creep is a real thing. People were getting more fluid than they should. Multi-center trials nationally, big deal. Fluid creep is real, so this turned into the modified Parkland. It's a 3-tiered formula based on the age of the patient. So instead of 4 for everybody all the time, instead of 4 mLs per kg per TBSA, it's 2, 3, or 4. It's 2 for garden variety adults, incidentally half of what the classical Parkland formula would say. So 2, 3, or 4. 2 for a garden variety adult burns, 3 for kids. And again, if this is an 11-year-old who's bigger than me, and there's plenty of them, then we might lump them with the adult category if they're over 40 kilos in weight. Why would I use 4 for electrical?
You don't know what's going on inside.
That's exactly it. There's probably some skin damage, but there's also probably some deep structure damage. The way that electricity flow works, the 2 places in the cross-section that have the highest resistance to flow, least conduction, greater resistors, is the epidermis, but that's super thin. It's going to resist heat, keeps going. It passes through dermis and fat pretty easily. It loves nerves, keeps going and fries them as it goes. What's not a good conductor is bone. So it passes along the bone, meets resistance. It's resistance to flow that causes the heat. Therefore, you're cooking them from the inside out. Does that make sense? Damaging deep structures, which you can't see from the outside. So this is how we double it for electrical. Okay? And even then, we suspect we may have to go up if it's severe. But we start with it. So 2, 3, or 4 times weight times percent TBSA, excluding first degree. And I said LR, if all you have is normal saline right now, normal saline is better than hypovolemia. Okay? We're trying to stay ahead of burn shock, so we front load it, give the first half the first 8 hours. And in real life, you're just titrating based on how the patient responds. Okay, we have the formula. Formula says they should get blah, but an hour or 2 after I start, they haven't made a drop of urine. Whatever. I don't know. They were dehydrated. It's deeper than I thought. Whatever. I go up on fluids, et cetera, et cetera. So I titrate based on patient response. Now I know, as a general rule, you guys are not placing Foleys, yeah? Right? As my friend in Harnett County said, we ain't not touching the PPs. If they had a Foley, this is what we would be looking at to say, look, if I'm perfusing the kidneys, I must be perfusing everybody else reasonably well. And those would be our targets, 30 to 50 per hour for adults, 1 per kilo per hour for kids under 30. What's this myoglobinuria business? Has anybody ever had a patient in rhabdo? Okay, so what is rhabdo?
Breakdown.
Yes, the muscle tissue itself is damaged, deeper structure below the dermis. Myoglobin, the components, the fragments left in the broken up muscle, those are big fatty fatty molecules, and they will gum up the works for your nephrons. They'll give you AKI. So the analogy here is if you're seeing myoglobin in the urometer bag, they're peeing that, and what does it look like? It looks like Bojangles' teeth. It's that dark, amber, red color. And I'm not talking red as in traumatic Foley insertion, a little bit of bleeding from the meatus. No, I mean, continues to be that color. Then we suspect myoglobin, and what do? We go up on the fluids until this is our urine output. So what we're trying to do is flush the kidneys out, basically, to prevent AKI. I know likely you won't sit on the patient that long, but this is the projected course if you're having to sit on a patient for a longer period of time. All right, so let's play this resuscitation application, okay? Pam, if I could ask your good graces, lights up, please, again. Thank you, friend. She's going to have carpal tunnel on her shoulder. All right, so we've got this is JJ. So skulls to anterior trunk, bilateral thighs, right forearm, okay? Burns are blistered, moist red, blanched, and are very painful. What does that sound like in terms of depth?
Second degree.
It's a classic description of second degree, okay? Partial thickness, another way to say that, meaning we're partially through the dermis, okay? Now, for the size, since it's second degree, do we include it or not? Yes, we would include it. Is rule of nines appropriate for a 2-year-old? Well, they're better tools. They're better tools. So look at that Lund-Browder chart. What was burned on JJ? It says anterior trunk. No, I don't have a picture, but that is based solely on my text. It assumes it's the whole anterior torso for the moment. Anterior torso, which column? Second column, because he's 2. Column 2, anterior trunk, 13%. What else was burned? Bilateral anterior thighs. It's anterior, so it's only half. So instead of 6.5, I cut it in half, but it was thighs plural. So I doubled it. So I'm back at 6.5. Okay? I do not want that to be voodoo. I'm happy to explain it again if it's not clear. 6.5 plus 13, that's 19 and a half. What else was burned is forearm. We didn't specify, so we assume it's the whole circumference of it. Lower arm 3. 19 and a half plus 3, 22 and a half. I do not want that to be voodoo. Are y'all okay with how that rolls? Let us agree, if I used straight up rule of nines, then I would say my leg has some, my leg has some, my torso has some, my arm has some. 18, 18, 18, 9. Vastly overestimated. Does this make sense? That'd be what? That'd be 63% versus 22%. 3 times too much. So again, rule of nines is great, but Lund-Browder, when it's only part of whatever that extremity is, then it's much better for kids. So let's go back and see what we do. Now, let me talk reality-based. 22.5, that is perfection. I could get 3 attending physicians in the tank room and they would all come up with something close to that but slightly different. Nobody is expecting that you would come up with 22.5% burn. If you call this a 20% burn, 25% burn, that's really pretty darn close. If you're coming away calling that a 63% burn, a 50% burn, or a 5% burn, you're like way off. So 20-25%, I'll be like, that's really great. You did a great job. I'll take you to coffee, whatever. That's great. Does this make sense? For teaching purposes, sure, I carried the decimal, but nobody's expecting that degree of accuracy. Okay? What do you do with a number? We use that for our consensus formula, right? Now, before I've done all this, have I started fluids on JJ yet? I should have, right? Remember way back in ABCs and circulation, I got my access, IVs or IOs or trivial, whatever, and I started something. Remember that 3-tier formula? It was 125, 250, or 500. How much would JJ have gotten? 125, because he's a small, tiny human, right? What else would I be concerned about before I've even done my burn map into Parkland and all that, besides fluids, hypovolemia? Well, absolutely, I'll address airway, anything that would be life-threatening, and along with the resuscitation fluids for the circulation business, remember we said, keep in mind for younger kids the risk of hypoglycemia as well. Keep that in mind. So I got fluids going until I could finish my primary survey, do my exposed and examines, map my burn, and now that I'm past the life-threatening stuff, now I can tweak this with the consensus modified Parkland formula, whatever. So what's the formula? Yeah. So the multiplier. So weight in kilos, 15. Surface area, 22 and change. And then 2, 3, or 4. Which would I use for JJ? 2, 3, or 4? 3, because he's a kid and it's not electrical. Okay. So multiply those two together. 3, 15, 22. About a liter, give or take. What do we do with that number? That's what they need over the first 24 hours. Cut it in half, front load that in the first 8 hours post-injury. So around 60, give or take. Does that make sense? That's resuscitation fluids, meaning I'm replacing what he's third spaced out, or what he will third space out, I should say. For basic metabolic needs, that's my maintenance stuff, and I would think about something with dextrose for him so he doesn't bottom out with his blood sugars. Don't worry about that part, don't overthink that part, but some also for maintenance, okay? Case study 2, we'll do one more after this and we'll take our break here. We've got a 15-year-old. He's a kid, but he's 70 kilos. He's bigger than me, so we're going to think of him as an adult. House fire. Before I even go further, scene survey, what are you thinking when I say house fire? Yeah, inhalation, airway, much more that could trump the burn proper. Burns cover the entire bodies. Sleep on the couch, house fire, he was wearing Timberlands, so the feet were spared, but not much else. Okay? Burns appeared khaki dry, don't blanch under insensate. What's that sound like? That's your classic 3rd degree. Now, for size, for the Lund-Browder chart, sometimes it's easier for big burns to subtract out what was unburned, what was spared. How much is a foot for an adult, says Lund-Browder? 3.5, so 2 feet, 7, so 93%. Does that make sense? I can tell you, when I'm doing this, when I'm subtracting out what was unburned, this sucks. That means this is a really bad burn. Does that make sense? It means we're closer to 100% than we want to be. So far, 93% full thickness and possible inhalation. What are you thinking that nobody said out loud yet?
Oh, shit.
Well, yeah. Oh, shit, yeah. For me, it might be other words, but the same general sentiment, yes.
He's going to die.
Yeah, we're thinking he's going to die. And I agree with you, that's almost a certainty, except for one thing on here. The fact that he's 15. He has a chance. It's a small one, but he has a chance. If he was 65, it'd be a different conversation. Does this make sense? Everything needs to go his way, but this has been survived by 15-year-olds. Okay? Does this make sense? All that to say, odds are against him, which means the things we do on the front end matter a great deal as to whether he's going to survive or not. Does this make sense? So I agree, deck is stacked against him, but we'll try to do all the things right to give him a maximum chance. 93%, what do you do with that number?
Times kilograms times
2, 3, or 4?
4.
2 or 4? 2. So garden variety, not electrical, so we would take 2. Now, here's the caveat to that. We suspect inhalation. Now, I haven't done a bronch to confirm, but my God, if he was burning that bad in a house fire, there's going to be some carbon in there, some soot in there. Where on your lung router chart on your packet, where are the lungs? Where do the lungs appear? They don't. It's a trick question. But the whole point of the lungs is surface area. That's why you have alveoli. That's the whole point. Which means if he has inhalation, surface area involvement there, his resuscitation needs may be even more than this. Okay? 13 divided by 2 divided by 8, so 800 an hour. The Jaycee 24 gauge in the thumb is probably not going to do it. It's going to need lots of access. Does this make sense? But this is a complicated patient because he might have increased resuscitation needs, but if his lungs were involved and are inflamed, where is he going to have cap leak? Everywhere, but especially in the lungs. Pulmonary edema is going to be a short trip away. Does this make sense? So these are exceedingly complicated patients with a very narrow therapeutic index of a little too dry, a little too wet. Both are problematic for these patients. Y'all okay with that? Does that make sense? The last one, then we'll break. All right. Door number 3. Well, actually, let me back up just a second. I'll apologize. I know we don't do, you don't touch it pickies, but how do we know for JJ if we've given him sufficient resuscitation fluid? Well, yeah, we might have wet, absolutely. By the way, I don't think I mentioned this about diapers. When you do your expose and examine, please, please, please take the diaper off as soon as possible. I've seen this before with scalds especially. People take the clothes off, but they forget about the diaper. But that holds heat and moisture, so I've seen 2nd degree, 3rd degree, because it trapped hot water or hot whatever in the perineal areas. This makes sense. But we might weigh diapers. If we had a Foley, how much output do I want for JJ? 30 to 50 for adults, 30 to 50 an hour for adults, and for tiny humans, it's a weight-based, and we say 1 ml per kg per hour. So for him, smaller human, I'd be satisfied with 15 an hour. How about the house fire 15-year-old? 30 to 50 for him. 30 to 50 for him, okay? All right. 40-year-old, 80 kegs, electrical injury, falls from the bucket truck. That slide early on. He fell, was found on the ground beside the bucket. Hands and forearms black and dry, leathery chart. What's that sound like? Yes, whole thickness, okay? The lung router chart says a hand and a forearm is 5.5 times 2 of them, that's 11. What do you do with the 11? Times weight in kilos, 80, times 2, 3, or 4? 4. Why? Electrical. And there likely is deeper structure injury beyond the 11% that I see. Okay? So, blah, 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 220 an hour. Now, I start my 220 an hour, or I get something going, 15 minutes after I start treating this patient, I notice that his blood pressure is crazy low. Maybe a 60 over P. What are your thoughts?
Well, he fell, so there's probably something else. Yeah.
Right? So we know we have a potential mechanism, and again, 15 minutes after even a severe burn, early hypotension, something else has happened. What could be the culprit if he fell? It could be busted pelvis, rib busting, lack of the liver. What else could it be? T6, for example, spinal shock. I would be very interested in heart rate. How does the heart rate compensate for low stroke volume? It should go up, right? If his heart rate was 140 and almost no pulse, I'm thinking hemorrhagic shock. Does this make sense? If his heart rate was 60 or 50, I'm thinking, where the hell is my compensation mechanism? So either spinal shock, and that's that I'm thinking about, I'm looking for it, or current went right to his chest, I want that 12 lead, do I have a new heart block, as an example. Now again, I'm leaning, there are multiple suspects. Or if it took a little bit long, if this is closer to 30 minutes, maybe he was compensating and I moved to decompensated shock and I'm about to die, basically. Does this make sense? But again, early on, if they're hypotensive, look for another culprit. All right. Let's call that break. Let's say I've got, what's that? 3:55, about, come back 5 after or so, and we'll do the home stretch. I'll try to think of some more dad jokes for us. Well, you'll appreciate this one. I'll look in my database. Never gets old, except to everybody but me. How long have you been playing this game? Clearly, you have to go on experimented 2 years under your belt. Always awesome.
I've been full-time for 27 years.
Okay, right on.
But Linda, your comment is 4 hours.
Burn Center up there. What can we
Well, I'll
do?
sit here.
That's better down here.
If they get rid of it, it ain't my fault.
What do you think?
I've got
Do you
it.
think it's something since you've
They
got
get
one,
rid of
two,
it, it ain't my
deliveries?
fault.
Not your fault.
That's right. I'm trying to.
Not why you wanna go over.
And we had a
That's right.
couple year gap when nobody was doing outreach at all until I came back in January, so. I definitely want you guys to feel supported, because you're the tip of the spear in the field, right? So pretty much everybody who comes to us, somebody wants to be here first, right?
Yeah, that's true.
So what's your favorite part of the gig?
I don't know. I got- Well, so I got started in the rescue service. Yeah, years ago. We had a volunteer rescue
Your
squad.
name is off the beginning.
And that's where I got my start.
I know.
And then I volunteered for 4 years and then I got hired.
That's what
I was
my
hired
favorite
full time. I enjoy the rescue service.
That's easy.
I really do. I mean, but, I also enjoy, being able
But you don't
to
make her money.
No.
treat my patients,
I think all of us combined.
I don't make her maid's money.
I guess I would have to say I probably would prefer, if I had to choose between a complicated medical patient and a trauma patient, I'd probably take a complicated patient. Because to me, trauma, and trauma has biggest, you manage the airway, you plug the holes, and you fill them back up, basically. With a complicated medical problem, you actually have to use your brains, to think through the problem.
Do I not see?
You guys have,
Do I?
I mean,
Yes,
it's
what
like.
problem do I not see? That's the culprit.
Right, and
Or, what?
probably one of my favorite patients, which most people hate, is a congestive heart failure patient that also has COPD.
Things that.
So, which one you going to treat first?
Yeah, I'll go with
And the way I personally look at it is, well, which one's going to kill them? If it's more respiratory, then I'm probably going to lean towards the COPD. And if they're having, GED and edema and they have rails and blah, 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 then I'm going to lean towards the CHF side of the house, and I'll go that route.
For in the field stuff, you guys
Hopefully,
have that good problems in the field, you all have.
Now, we're actually just starting a program where we're going to start carrying over, which I'm really excited about.
Candy, just think about that.
Oh, yeah, and there's no telling
once that program gets up and running, and, we actually have it on the trucks.
Well, hold on, because
I think we're gonna have an opportunity to do good things for
I got
ourselves.
two shot the same day.
Yeah, they told her to meet me.
I'm fairly excited about
They
that.
don't have time to do that stuff. So, 5 years.
Oh, we sent.
Well, I think if you must have what's up,
That's the second time. These were a joke. They were actually a joke, because they glow in the dark. They were a joke.
But you're just trying to match your insignia on your jacket to like up the fashion ensemble.
No, it was a joke. They were like 20 bucks.
Do they actually have lenses or do you just?
Yeah, oh, I can fly on bat without them. Super blind.
I know the feeling.
Super blind. Can't do it.
I know the feeling.
Yeah, when I went to
Oh,
switch my
I did that,
laptop.
Mary.
I know it's just a joke. I know, I meant like, so as far as I can see, I was seeing over down the road.
So, you were talking earlier about, don't be so quick to innovate.
Yeah, this is important.
Yeah.
But last time.
And the very first thing that went into my mind was, well, that's fine for us, but, a lot of times if we have a critically burned patient, we turn them over to helicopter most of the time. Provided there's one available. And, of course, we take them, But, that's usually the first thing they do. Is
Use advantage of the bird, that's true, or they don't want to.
That goes for like any patient though, really.
I had an elderly male, this has been years ago.
Yes.
I felt so sorry for this guy. He was at home, he was burning some, just some leaves and some limbs and stuff. He walked out to check on his burn pile. As he approached the burn pile, he tripped and fell face first into the fire. And when we got to him, his beard was burning, and he had soot in his mouth, but he was working it. His vitals were great.
Yeah, and, he did no difference.
Talking fine, it was important. Other than some supplemental or two, we did nothing.
Yeah, boy,
We didn't feel the need to. Of course, now we don't RSI anyway. But, so we flew into Chapel Hill, and the first thing the crew did, when I saw him, was when I put down
And then I
into.
can go over and do filters so that I can.
I'm not gonna say that they were wrong for doing
I can search
that,
trucks or.
because, ultimately, that may have saved his life. I had no idea what the end result of that case was.
I would say
You
the
give Ken the,
So then I
yeah,
can
the patient has like a
culture changes.
But you have access to like
Air care. Or they like to just put it on some of that level of stuff, right?
Sure.
There's some. Having said that,
Does feel
we're pretty frank about how hard it is to change culture in those groups as well, where it can be just as water. If I could, whatever, stand upside down on one side, whatever, and then he goes his, it's almost like an ED to that, how big of an IV can I get in, I'll go in for as good as I can, or whatever.
somebody we do.
And it's all the charts that we're
Well,
not
see, we were in the different area.
Should I?
We had it set up in our system. So I was looking.
So I would say that's part of it, the other part
So
is
then, so
like.
this is gonna give you, go to your budget. So
Side
this
effects.
is where it says treatment prior to shot. So that is gonna be all the ways given by
A
us.
different calculation once they're in the ED or control fire.
Yes.
You have all the resources versus tripping into an emergency. Everyone we get a history of the process.
Some of those may also give additional doses, but that's gonna give you.
Speaking of people, it's easy to come from resonated and said.
And I didn't know you were coming this afternoon, so when I called back, I told her the report was in there, so I could come share it tomorrow.
Well, see, this is where we had to give back this.
The thing is that most of the time, fire department makes us do it, so they already have established.
Yeah.
It is a pain in the ass to get through
Well,
anything.
and that, see, that's how we had it set back up. And I was like, in my head, when I said this, I was going and I said, I just searched those here for these two things.
Right.
It's easier to do that.
I figured out that, Tom, I heard that it's
Oh,
way
you don't know.
easier.
Just going from here, so I went from here for a few years, and then I went to Harnett, and then I came back. Because Harnett are about what they're not, and that was not something that I was used to here at all. I was used to, you get your race for you figure it allow you to drive to the hospital and maintain it and get there. And then over there, I was being a full private room call for this, like, why did you stop for this, why did you stop for that? I'm like, well, if I can maintain them long enough to get to the hospital, you know, buy that. Then that, and not buy them too,
And I would argue again.
that's,
All right,
so it's one of the same type of situation.
It's not EHR, where
It's a subset, it's a great reflection of broader situation. And if you can get around with this basic stuff, you're not going to put, right? You get by with cyclones.
They dragged it all, and they because they had a regular fire and everything. And it was just from the
One of those things why different people do
And
in settings.
never admit to it, right?
All right, you guys ready for round 3 of world domination? I know she is. She's texting her friend saying, we're doing round 3 of world domination, right? BRB.
Trying to figure out escape route.
Escape route! Yes! Yes! The spirit of the exercise here is more for the kind of the beyond that first hour. Like, what are we going to do to maintain this? I just want to, the purpose of this slide is really, it's about humility. We have the Parkland Formula, all the stuff that says this is how much the patient should need. But we've all been fooled by, you know, as we say, if you start shooting on yourself, bad things happen. Right? Don't shoot on me. And you do other unpolite things in public. If you shoot on people, then the next thing you know, they're masturbating. What's your name for it? Shh. But my jokes. More dad jokes, Dave. There we go. They asked Potassium if he wanted to join the periodic table. He said, okay.
That's a bad joke.
It is. They asked Sodium. Nah. They asked Chuck Norris. He said, I only believe in the element of surprise. Right? You want to hear my poop joke? Never mind, it stinks. It's not my favorite, but it is a solid number 2. I'm on a roll. That's why there's butter on my pants.
Be here all day, folks.
That's right. So some things to think about for these complicated medical patients who then are burned. Does that make sense? Because they got all the other stuff happening and then the trauma overlaid on top of this. But I always thought Acute on Chronic would be a great name for a band or an album anyway. But so is the burn deeper than you thought? Is that first degree really second? Or is the third degree like really deep third degree, etc.? The inhalation stuff I've mentioned. Is this a polytrauma that I've missed? I see the burn, but I've missed the fact that this is a retroperitoneal bleed, whatever. I missed that. And I'll just offer this part. It can often be missed, but as a pullout, I was listening to a radio program. They're talking about farm workers. Now you can extrapolate this to anybody who works outdoors in the heat, but this was looking at farm workers specifically. This is back in the summer. And they were saying they were really interested at the conditions of farm workers broadly, but they wanted to see how does dehydration affect them. And again, you extrapolate this to any patient population, any population period, people who work outside often. And so they wanted to see if dehydration was an issue, if so, how many people, blah, blah, blah. So they drew labs, drew blood samples to get a H&H, hematocrit and hemoglobin, in the morning before they would go out and work outside for 14 hours a day in August or whatever. Then draw labs when they came back. And they found in like 60-70% of the people after a single shift, one day, and heat without adequate hydration, probably 60-70% of them showed signs of AKI after 1 day. So that was sobering thing one. And that might be somebody that you're taking care of, or the retired farmer who's, you know, working on his tractor or whatever, or the skilled nursing home. This, you know, the last time somebody brought her a pitcher of water was 3 weeks ago. You know, like we know this dehydration is real. Back in that same sample study, the part that was even more sobering was there was something like 20% of the people that they drew labs on, in the morning they were already showing signs of dehydration in the morning before they even went out, because of this chronic cumulative effect. So it's interesting to think about. I don't even know what their baseline status is. Okay. Well, this is the thing. They say, and you say beer's not, and Mountain Dew diuretic, or me.
Watch your mouth.
I gotta do the do. But I'll drink a pot of coffee when I get up, and then I'm like, I should know better than this, because this ain't no balanced resuscitation. That's all inotrope and diuretic, right? But I need to balance it. So a lot of people, all of us, often may have baseline dehydration, and the patients we take care of. More to the point, the alcohol is a tricky one, okay? Now we know it predisposes folks to injury, of course. Lots of traumas are preceded by, honey, hold my beer. But what can fool novice practitioners is, 3 hours in, the patient's peeing buckets, peeing bunches and bunches of fluids. That must mean that I'm over-resuscitating, so I should turn down the maintenance fluids. And I've seen this happen many times. And if you turn them down at just exactly the wrong time, when they're intravascularly dry, about 30 minutes later, well, look at that, 70/40 blood pressure. Ah! So if this is suspected, you must be cautious. This means their peeing buckets, they're going to need more fluids, not less.